Good afternoon, everyone, and welcome to our External Consulting webinar series. My name is Shannon Kautzman, and I serve as a unit head within Management Engineering and Consulting. During this webinar, we will discuss Mayo Clinic's Patient Access Program. This program partners with the departments and divisions within the organization in order to manage all access aspects of the patient's experience. First, I would like to share information about Mayo Clinic and our department, Management Engineering and Consulting. Mayo Clinic consists of multiple locations. Our main headquarters is in Rochester, Minnesota, where we see about 400,000 patients a year. We also have a community and regional health system, which is set up in 4 regions with 18 hospitals and 75 communities between Minnesota, Iowa, and Wisconsin. We also have a location in Arizona, Phoenix, and Scottsdale, and they see about 115,000 patients a year. Our location in Florida is in Jacksonville, and they see about 110,000 patients a year. Here's some background on the Management Engineering Consulting Department and Mayo Clinic. ME&C was founded in 1947, and we've been engaged in the healthcare consulting business for over 70 years. Our mission is to partner with clients to achieve the best patient experience through objective, innovative, and integrative business consulting. And our key capability is end-to-end internal and external consulting across practice, research, education, and administration within an enterprise setting. Here are a few details about our staff in Management Engineering and Consulting. We have 200 team members made up of health systems engineers, project managers, and support staff. We pride ourselves in attracting and retaining a very diverse workforce. We have been able to attract diversified and talented staff that have lived and worked in 36 different countries. A key ingredient to our excellence is our diversity in background and training. The varied perspectives within our department enable us to provide our clients with innovative ideas and unique perspectives. These circles are a sampling of the educational and professional backgrounds of the individuals within our department. We have 5 service lines, and I'd like to cover those today. We have our Management Systems and Processing Engineering service line, where we apply a variety of engineering tools to improve business performance. We help integrate multiple disciplines to study and solve complex problems using a systems approach. Things such as Lean, Six Sigma, systems engineering, advanced analytics, and simulation modeling. Our next service line is strategy, design, and execution. We develop, refine business objectives, define key business measurements, do benchmarking, analyze data, develop recommendations and proposals. Our next service line is change management and organizational transformation. We provide vision, design, and development. We do change management planning and help with implementation of best practices. Then we have our revenue enhancement and expense management service line. We do business process redesign, decrease operational expense, improve supply chain efficiency, and identify new revenue opportunities. Our last service line is project management. It's a structured and disciplined methodology project framework to deliver improvement plans to complex projects. Here is a highlight of some of the patient access projects that we've worked on recently. We've got things such as the scheduling FTE prediction modeling, where we can look at staffing models based on volumes and tasks. Occasionally we get asked to assist in certain specific areas such as E&T or the urgent care to look at different modeling for them. We also assist with telemedicine support in regards to their access program. This is just a high level of a couple of things that we've helped with recently. Now I would like to introduce our guest speakers. Our first guest speaker is Dr. Brian Crum. He is an associate professor of neurology at Mayo Clinic in Rochester, Minnesota. He received his training in neurology at Mayo Clinic and completed a fellowship in clinical neuropsychophysiology at Mayo Clinic. His clinical focus has been with patients with neuromuscular diseases. Dr. Crum currently serves as the Medical Director of Enterprise Office of Access Management and Vice Chair of Outpatient Practice Subcommittee. Our next guest speaker is Brian Klute, who serves as the Principal Health Systems Engineer for Mayo Clinic's Internal Consulting Group. His background includes banking, finance, high-tech, and health systems. His specific interest is in applying evidence-based approaches for optimal access for patient care, drawing on previous experience, including predictive analytics work in banking and healthcare. He's been involved in access system design for Mayo Clinic for the past 8 years. He's a graduate of the U.S. Air Force Academy with a degree in mechanical engineering. He also has an MBA from the University of Michigan and a second master's degree in analytics from Texas A&M University. We are thrilled that they are both able to join us today. We will start with Dr. Crum.
Good afternoon.
Welcome. Thank you for joining us today.
Yeah, thanks for having me.
In preparation for today's program, it's been noted that you have been the director at Mayo Clinic Office of Access Management for the last 12 years. Congratulations.
Thank you.
Can you tell us how a very busy neurologist with interests in clinical practice, research, and education finds time for an assignment outside your day to clinical practice?
Sure. Yeah, and it's gone really fast, but it's been enjoyable. And I think at Mayo Clinic, one of the things that distinguishes the leadership, at least in my piece of work, is that the physician is oftentimes partnered with an administrator. So at Mayo Clinic, a lot of the roles like this will have a partnership between a physician and an administrator, and that in effect helps the physician maybe need less time to do some of that work and provide interaction when needed, with the administrator doing a lot of really the heavy lifting, so to speak. That being said, some of my time is in essence paid for by Mayo Clinic to do some of this administrative work, as the access task is a large one, and it does require dedicated time for meetings and other discussions. But it's really that partnership which is quite important, so that it doesn't take as much of my time during the day. Although in reality, access is pretty much a 24/7 job, whether or not I'm working in the clinic or in the hospital. There's always access issues, so they don't necessarily wait either.
They're always around, right? Tell us about your interest in personal interest in patient access, and maybe a little bit about the Office of Access Management.
Yeah. So when I started on staff, it was a few years into that when I was asked by our chair to be involved with what we call our practice committee. So most of the departments in Mayo Clinic have a chair, obviously, a chair of the department, but they also have vice chairs that help to manage practice, education, and research, and nowadays even things like quality. And so I was invited really to become involved in the practice, and I felt it was very interesting to learn about how things worked and how to maybe make them better. And I think as a physician, we spend a lot of time doing the same thing. We see a patient, we're presented with a complex problem, and we need to think through how did this get to where it is now, and how can we try to help it. So in a way, it applied some of the clinical reasoning skills into just a different setting. And so I was involved in hospital and outpatient practice in my department, and one of the things that I was really interested in especially was the clinic and outpatient access, and how did scheduling work, and how come we can't get certain patients in, and there's always a lot of struggle between physicians or nurses or providers maybe not being always satisfied with the kind of patients they're seeing, and on the flip side, patients sometimes not being satisfied with access into providers. And so it was an interesting problem. It was a big problem, and I think I spent more time on that, and that really led into my role within the Office of Access Management. And the Office of Access Management is now really what we call an enterprise office, which essentially means we have individuals at all of the Mayo Clinic sites in the Midwest, in Florida, Arizona, and Rochester. But beginning about 10 years or so ago, it was really a Rochester-focused job. And our role really was, and still is, I think, to take the kind of patient journey from the point at which a patient says, I would like an appointment at Mayo Clinic, or their referring physician says, I want you to go to Mayo Clinic. From that point to the point where they essentially go home, and hopefully having had the appointments they need, at the time they need, and in a satisfying way from an appointment scheduling standpoint. Our office really, in essence, owns that process. And so it offered an opportunity really, again, to look at all of the challenges we have with access and really try to make a dent in them. So that's really what our office does, is really the end-to-end process like ME&C does. End-to-end, we kind of think about when you want to come to when you go home, we're kind of involved with that process.
Absolutely. What do you think has really changed? And you said about 10 years ago came more enterprise. What else do you feel has changed in those last 10 years?
Yeah, well, I think from the patient side, I think things have changed a lot. Clearly with the advent of digital capabilities, so patient portals, apps, the desire to communicate more quickly in an electronic fashion has certainly changed quite a bit. I think also our window into patient expectations and patient experience has changed a lot over time. We get more feedback from patients, we solicit more feedback from patients. And I think more than ever, I think the expectations from the patients is quite high, to make sure their time is utilized well, make sure they're seeing the right people for their problems, and I think in general maybe a little more invested in trying to do work up front to get things done right when they get here.
Sure, that makes sense. Would you be willing to share with us maybe a few of your exciting innovations or strategies you and the team in the Office of Access Management have been able to introduce over the past 10, 12 years?
Sure. How long do we have? No. Yeah, I think there'd probably be a few that I would highlight, and I would say some of these things are work ongoing too. Sure. Early on, one of the things that we really focused on was how our appointment offices are structured. And there's always a lot of debate in different institutions and in places I've been to or colleagues I've talked to about the idea of what's centralized and decentralized. And so there's really been a couple of camps over time on that here, but what we did probably about 8 or so years ago was look at that appointment making staff. And what we found was that we had about 56 different appointment offices, and the people making the appointments were governed in many different ways in terms of the types of individuals that trained them, that supervised them. It made it very difficult from an institutional standpoint to do something widely across access. And so we discussed the possible solutions to that. Some would say, well, we just need one big office and let them schedule everything. And one of the constant battles we fight is really the tension between making it easy from a patient standpoint, just let's get things scheduled, but on the practice side, it's a complex practice. How do we get patients in the right spot at the right time with the right things set up? And so at the end of the day, really where we settled was, I would say, a decentralized model where individuals may work in a department, physically even, but they are governed through our Office of Access Management. And so in Rochester, we have really a central appointment office where if you pick up the phone and call or send an email, you'll hit that group. And that was an OAM really owned and operated group. However, the 56 different appointment offices, it was not all the same. So we did work to really take the individuals doing that work in appointment scheduling and really wrap them underneath the OAM family or banner, if you will. And that was challenging because certainly I had a lot of discussions with people who, they want control over their people who are doing their work. And so at Mayo, really, we say that OAM, our office, really works in a co-management model with the practice to try to be successful. But that was a several-year project that eventually led to appointment office staff really being governed within OAM. And what's happened over time is that many of those appointment offices have subsequently moved physically from where the clinic is into an off-site support center. And a lot of that has been driven by the growth of the practice. It's very hard to just add space. And so in many departments, they've had to look at the non-clinical space and made a decision that some of these individuals could be moved off-site. And I think this really set us up for success in being able to do that. We do have some individuals that work from home, but that's a relatively small percentage of our population. But it does allow that as an opportunity potentially for some staff. So I think that was a big one. I think the other thing I would highlight would be just our ability to utilize analytics and data and metrics better. When I started in OAM, 10, 12 years ago, we had a couple of dashboards, and it was some pretty basic stuff. And I think over time, we've really tried to provide data and analytics to help manage the practice. And I think one of the things we focused on is not just providing data and metrics, but really providing some analysis of that. And I think that when I was sitting as vice chair of practice and having meetings with various groups, and here's a lot of data metrics, and people would nod their heads like, oh yeah, that's really interesting, but what does it mean and what should I do about it? And so I think over time we have tried to shift from just reactive approach to metrics to also a proactive approach where we've tried to look into the future and set ourselves up to be able to make adjustments to be successful in access. And so I think that's probably the other big transition that has happened over the last few years has really been the advent of better analytics and better sort of data scientist approaches.
Sure, that makes a lot of sense. So kind of on the flip side of that, I'm sure there was challenges along the way.
Yeah.
What were some of the challenges that you see that you saw and that you see coming forward with patient access?
Yeah, I think there certainly are. As I alluded to, there's a constant challenge between making it real easy for patients. I think we are expected in the access world to make it easy for a patient or a referring provider to get access to Mayo Clinic care. And that is a challenge. And we are trying to really walk the line between the ease of that and the complexity in the practice. I don't know that we've totally figured that out, but one of the things we've tried to, as much as we can, automate some of the thought processes, and a lot of this gets into using decision trees and algorithms to help schedulers do the right thing and schedule patients correctly. So I think that continues to be a challenge to balance the needs of the practice and the patients. I think the other challenge really is just training and educating a workforce and allowing them really the power to be able to do their work. The people who are in roles of scheduling love to schedule patients. That's what they do. And sometimes we put up barriers to that. And so I think that's a constant challenge as well. We try to strive that our appointment staff will be trained well and that they have a very satisfying job and they stay with us for a long, long time. And I think that's always a challenge. Also, we have, even within the clinic, people move into different positions and there's turnover, and it's very hard to have very seasoned individuals who have been somewhere for 20 years and know things well, and then they leave and there's a big hole to fill. And how do you make it so that training and that onboarding really is more effective? I think that is definitely a challenge we work with. And then I think also, just like I said, playing in the digital space and being able to interact with patients and prospective patients in the way that they're used to from other interactions they might have with other companies and other businesses. I think we, as Mayo Clinic, are trying to move the dial a bit on that, but that's been a challenge too.
Sure. You always kind of hear the rumors or the myths that are out there. What are some of the myths around patient access that you would love to dispel today?
Well, yeah, I think I hear a lot from maybe institutional leadership or others in probably even outside of medicine who maybe don't appreciate access as much, that this should be really simple, and it's not. And the goal is to make it simple, but have the sort of rules, if you will, or their algorithms on the back end to make things work. But I think it is very it's a complicated business. And so I think sometimes the frustration is that it just is not as simple as it may seem. I think the other issue that we deal with a lot here, and I don't think it's unique to Mayo Clinic, but on oftentimes the employee or maybe provider side, when things don't go right, there's a thought that it's broken, everything's wrong, access is broken, scheduling is broken, we need to blow it up and start over again. I've heard that a few times. And, at least here, a lot of the times, the events that occur in scheduling are at the direction of the practice. And so I think it's important for us to work really closely with the practice to design a system that works for them. And that oftentimes when it doesn't work, it's because something changed and nobody was made aware of it, or the practice is different, or something's evolved. And I think it's just points that, that access system has to be constantly maintained and monitored. Because things do change, and again, oftentimes when something goes wrong, it wasn't that the system is broken or something needs to be totally redone. Sometimes it's human error that occurs, and sometimes it's what a patient has said, and sometimes it's just things need to get updated, and it's not necessarily broken.
Sure. When you run into those things that feel like they're broken, what are some things that the Office of Access Management does with the practice to try to help fix that?
Yeah. So we do certainly manage sometimes by anecdote, but nonetheless, I think, when there are problems that arise, oftentimes our staff will look at the individual situation. So most of the time it's, this patient, something happened with this patient, whether that comes from the practice or the patient or our Office of Patient Experience, where something didn't go right. Our staff will oftentimes go into the record and piece together what happened. So there was an appointment request, how it got scheduled or maybe rescheduled, what orders were placed by the provider, how those orders got scheduled. Oftentimes there may be an event where a patient have called and needed to reschedule, and that isn't easily found unless you dig into the system and see the notes that were left by those in scheduling. So we'll dig into those one by one if there's individual maybe anecdotes. I think the other thing, we will spend time sometimes just ad hoc pulling reports. So we had an example a few weeks ago, a massive storm, and a lot of questions like, what did that do, to rescheduling or cancels or no-shows, or what do we need to do about that? So that would be a situation where we, on a very short-term basis, go and pull a report and try to look at it and understand what impact is that going to have on the practice. Or additionally, it might be a question of what patients didn't make it here because of the storm, and can we get a list of patients that we might need to contact to get a hold of to get them back here. So we deal with both that kind of patient by patient and also maybe an acute problem where we may need to start digging in really quickly to look at data.
Sure. That sounds great. Do you look to other healthcare organizations or other industries as you're kind of coming up for ideas or processes to improve patient access?
Yeah, I think we definitely do. We interface with others within the access world and some other institutions. And there are a number of individuals that may have been at Mayo Clinic and now they're at another institution, and we certainly oftentimes keep tabs on what they're doing and what they're struggling with. And I think you can't help but compare yourself to other businesses. I'm sure everybody has had an experience, whether you're making a haircut appointment or a dinner reservation or a hotel. If you're like me, you think, geez, but that really worked good. Why don't we do that? Mm-hmm. And so I think many of us are constantly bringing up, I had an experience when I did this, we should do that. So I think we definitely compare ourselves to other organizations, and that speaks to some of that digital capability that I think we probably are lacking a little bit, that we're trying to move forward. I think also from a customer service standpoint, we take that seriously too. If you have a good experience at another business or healthcare institution, it's good to sort of think about how that would apply to Mayo Clinic. So I think we're constantly looking at that, and we have oftentimes benchmarking exercises where we may want to find out, with help from maybe our marketing colleagues or others, what do other industries do? We work with our electronic health record vendor a lot of times and ask, put us in touch with somebody who can help us understand how to utilize that option, or how can we make this better. So I think it's definitely very important for us to look outside of Mayo Clinic and see what's out there.
For sure. Thanks. For the audience joining us today from all over, what lessons learned as a patient leader would you want to share with them?
Well, I think in our access work, probably a few things I would share that I think has made us successful. One, maybe first of all, has been institutional leadership support, and I think that's crucial. There have been initiatives that we have been tasked to help with that if we really didn't have that backing from the Mayo Clinic institutional leadership, meaning CEO, dean of practice, or depending on your structure, a vice president or director, somebody who is in the upper level leadership of the institution, if you don't have that support, it gets really difficult. And so I think that's really a key, is that you really have to have that if you're going to be successful from an access standpoint. And a lot of people talk about it's important. Yeah, access is important, but you really need that backing. There are many times where we really relied on those high level leaders to, in essence, be sort of the first attack. Get the word out there, explain the message. Why do we want to do this? And that is really important. So I think getting that high-level leadership support is crucial. I think the other thing that I feel has made us successful has been the connection with the practice. So we have individuals within our Office of Access Management. We call them practice partners. They're analyst-level individuals, and to a certain extent would be similar to individuals in your group or the ME&C group. But they are really assigned to practices. So neurology, we had a person that we could go to with really anything access related. They may not be able to fix everything, but they knew where to go to get the information. And I think that allows two things. One, from an OAM standpoint, we get a group of people who really understand what's really happening out there. And sometimes until you're a couple levels down, you don't really know exactly what's happening. Even a department chair or a practice chair of a department may really not clearly know what's happening in the appointment office. And so these individuals help us understand what's going on in departments, and they can be really helpful to share the message too. And like I said, we've had several initiatives where it might be initiated from the CEO or the dean of the practice, and we, in our mode of change management, constantly have to have these discussions and explain, why are we doing this? What's the benefit? And so those practice partners allow a way that we in OAM can share a consistent message with all of the practices. So those individuals, I think, have been really critical. Without them, then my own opinion is that we become, like a lot of other places, we'll provide data, we'll provide a little bit of analysis, but we really don't have anybody who knows your practice well. And that allows you as a practice to say, well, you don't understand, so this doesn't apply to me, or I don't really agree, I want to do it differently. But when we have that practice partner involved, we really cut through some of that, and it allows that two-way communication and I think more success. So I think those two things would be two of the bigger ones that I think have been really important over the last probably 10 years.
Sure. It sounds like they can kind of transform some of the data to the practice and back and forth. And
yeah, so I think they play a big role, sometimes in the translating too.
Yeah.
There may be an institutional access initiative, and they help really explain, what does that mean to that department? What do I really need to do? A lot of departments will say, that's fine, but what do I do walking out of here tomorrow? What do I do?
Right.
And they can really help with that.
Sure. So if you were to give a suggestion to people that are maybe starting down their patient access journey and trying to figure out, where do I start? I heard a little bit, organizational structure and building in some of those key components. Is there anything else that you would highlight for folks that maybe are starting off down that path?
Yeah, I think the other thing that I would highlight probably is having the data access and metrics behind you. I think data can be really powerful, and having a problem and showing data behind it helps make your case rather than an opinion or a few examples. Like I said, sometimes we get caught chasing anecdotes and how things are broken and we need to change it. And usually the first question we ask is, well, where's the data to support your claim that this is broken? It's a little irritating. I'm sure people saying, it's broken, we have to fix it, and we want to step back and look at data, but it's a complex system, and sometimes the solution that a department or a practice thinks is the answer is really not the answer. And so I do think we spend a lot of time stepping back and saying, what is the problem you're really trying to solve? And starting with that, not starting with the solution.
Sure. That makes a lot of sense. Any other thoughts or things you would want to share with the audience for today?
No, I just think it's an ongoing battle. There's challenges that come up. Certainly have not been successful on all fronts all the time. I do think in our office too, though, in reality, everything we're doing is really for the patients, and I think that at Mayo Clinic is certainly one of our, if not the main value we operate by, is do things in the best interest of the patient. And I think ultimately we have to keep in mind that we're here not just for the practice and the institution, but to actually make the patient experience the most excellent it can be. So I think that is another thing I would just share, is making sure that all of your staff have that value, whatever it is, ingrained, so that when push comes to shove, they can fall back on one thing. And in our case, that's what is best for the patient.
Sure, that makes sense. We have one final question, a little tricky one. If you had a magic wand to resolve healthcare's biggest patient access issue, where would you concentrate your efforts?
Oh. Yeah, that's a tough one. One is difficult. I think one thing that I've always felt we need to do well, and I think in the future we can, is really design a system that it tries to be nimble over time. A lot of what we do in Access is we design a template or a rule, a schedule, and it's pretty fixed and rigid and solid, and that just runs all the time. And where we're challenged is to make changes. And sometimes a change can take months and months to work and to take effect. And so I think having a system and having a process to evaluate the system, even prospectively, to be able to make adjustments ahead of time so that your access system is giving you what you want versus looking at what happened last week and then reacting to it. So I think we're getting there, and some of the work ongoing is helping us, but that's probably where I would like to see us move more, is looking into the future, being nimble, making adjustments to help make practices the most successful.
Sure. That makes a lot of sense, knowing that how complex it is, and then how do you build it complex and then give it some flexibility to allow yourself to grow.
Yeah.
So that kind of makes sense. All right. I think that's all we have
Thank you.
today. So thank you so much.
Thanks,
Very
Shannon. Appreciate it.
informative. I'm going to turn over to my colleague Brian, who's going to give us an update on one of the projects that he worked on in the patient access space.
Great, thanks
Cool.
Shannon, appreciate it. Thanks everybody. We're going to talk a little bit about some of the same kind of concepts that Dr. Crum brought up in this project. This one is kind of looking more at the access and analytical aspect of things and how they can be a bit more predictive in nature. So our focus here is multidimensional, but we will take one aspect of it as we move forward through the project. So when I say multidimensional, thinking about access, like Dr. Crum said, it's very complicated. It starts off often with predicting demand levels, which might mean a forecasting model. Then knowing what service level you want to achieve, and that's going to feed into this project as we talk more forward in the nature of the project. But in the beginning, we're just predicting quantity. But then the middle part of this process is a bit more on that flexibility side that Dr. Crum mentioned, where you're trying to be nimble, you're trying to set up a situation where your slots and your capacity is flexible to that changing level of demand. And we can use simulation models and other types of optimization models, and this project was a part of that. But the thing we're going to try to focus on this presentation is we're going to focus on when things go bad. The last part of it is sometimes all these factors may still not work out just so right for the patient, and they may disrupt the calendar. And when I say disrupt, what I'm kind of talking about here is they may cancel, they may reschedule, they may no-show. Things didn't go as originally planned, and so the quality of our process now gets affected. And so this is part of a broader approach, like I mentioned, but again, we're focusing on when things go bad. So predicting the risk of this is important because we can then, at least proactively, manage it if we can do it in a prospective way. And so the reason you'd want to do this, and I think it's basically obvious, is that it's very costly to the clinic and also the patient too, because not only are we spending unnecessary resources from our staff level, but we're losing an opportunity to fill a slot that could be beneficial to the patient and to our staff. And at the same point, it could be something that could last forever. Perhaps the cancellation, the patient never returns. So we need to be able to proactively manage the situation and understand the risk, and then intervene ahead of time to try to make better decisions. So just looking at the disruption process, there is an event, and the event is the cancellation, and that's the middle of the graph. It's kind of, the line is kind of running right through it there, but I'm trying to highlight that the initial focus for this analysis was before the event actually happens. There can be many reasons why the event happened, and we're going to get into that, but we would like to make sure we know about this early, because the problem is that if it's coming later, it's almost like a no-show. The reaction lead time, which is the right part of this graph, if it gets shrunk to the point where we can't react, if we knew about it ahead of time, we may have been able to affect the situation. So again, the goal is to try to predictively know the situation and try to make decisions on it. Thank you. So using a few different techniques in this analysis, one of them was called multiple adaptive regression splines. And what it does is it kind of gives me gave me kind of a flavor for what the risk was for the disruption, whether it be a cancel or a no-show. And the upper part of the graph in the red area is kind of the increased possibility of it happening, the increased disruption region. And the lower part in the green is more of a less probability. And these were for specific medical practices that we looked at. And so what is kind of interesting here is the patient's almost speaking to us here, if you can read it. The box that I highlighted is that the patient actually wanted an earlier appointment. And that was mainly the reason they disrupted. Now, there's other reasons too. There's provider reasons and personal reasons and patient reasons, and some things not available. But the majority of these particular ones were related to wanting an earlier appointment. So that gave us a clue as to what to focus on with respect to this analysis. So this is an interesting graph too, because what I can take away and kind of point out with this graph is, if you look at checked in, these aren't the actual numbers, but they're very representative from a perspective of the fact that checked in happens many times before cancel and many times before no-show in terms of the number of days it takes from the point of making the appointment to the point of actually having the appointment. And it's this pretty common theme to see that they're actually increasing beyond the checked in, which in a sense gives us a clue that time is an important factor in this process. And we also heard that from the patient on the previous slide. So again, the higher these lags in time, the more volatile the calendars seem to be. So looking at this problem, we tried to be very comprehensive in our approach. And so this is a diagram that talks about how we develop the modeling structure. So the middle part of the diagram with all those nodes lined up on top of each other is all the different predictive models that we tried to run. And prior to that, it's all the data preparation that was involved in the project. So we basically tried to build a model off a subset of the data and then apply it to something it's never seen before so we can gain some confidence in its results. And we compared it at the far right, we can get a model comparison. And by doing this, we felt like we had a way of capturing both what we would say in the predictive world, the linear and the nonlinear aspects of our modeling, and to see if we can get the best answer possible in terms of accuracy. And accuracy is our goal. So one of the models that popped out that seemed really important was just something called the decision tree model, where we're trying to focus on the final result of disruption and see what factors are influencing it. And there are a few different factors, but the one I'm going to point out that really relates to earlier appointment desired is the bottom one there with the red box around it. I'm not showing the actual numbers, but what it's basically saying is below this region, things are okay. Above this region, things go bad. And so what we're trying to understand here is, what are those breakpoints? And Dr. Crum mentioned earlier that many practices feel that they're unique. And this analysis also promotes that as well, that these breakpoints were actually different for different practices. In other words, the patient was more sensitive in certain areas for certain practices and less sensitive for other practices. So knowing this is super helpful to us. And in a sense, you can almost call this the patient's sweet spot. these are some of the results. There's a lot of numbers on this page, but the far right of the page shows the inaccuracy of the model. And it was roughly 11 to 12% inaccurate. So we're talking, 89 to 90% accurate. And so knowing this information, knowing factors about the patient, knowing factors about the type of appointment they have, how long it took them to get in, all of these factors contributed to our accuracy levels. And it allows us to understand maybe ahead of time, for certainly ahead of time, what we can do, or at least we can highlight certain patients that have higher risk. So in the end, what are the takeaways from this project? Well, the takeaways are that each practice has its own breakpoint, and it's not really the practice, it's the patient's population within the practice. So in a sense, they have a sweet spot beyond which the patient starts to get a little bit more anxious and maybe makes a decision to disrupt the appointment calendar. And the lag between the appointment creation and the appointment date was a very strong, significant factor, and that contributes to these breakpoints that we can look at. And the other thing is that with the current modern machine learning approaches that exist today, we can achieve pretty high levels of accuracy based on multiple predictive factors, not just one factor, but each factor weighs in on the final result, and we can get a significant patient and financial impact if we act on these results. So that concludes our presentation, and it does highlight some of the different analysis that we've done in our work, in our practice, and it's something that we continue to do to emphasize what we can do for our patient and putting our patients first.
Thanks, Brian. That was very helpful. It was a nice tie-in between Dr. Crum's conversation and some of our question and answers interview with him and the work that you've done. So thank you. It looks like we've got a couple of questions coming in. So we're going to see if we can take these and get some answers for you out there. Is there some way we could discuss a second type of access? Say access back to the system. So if a group has been identified with patients at high risk for a 30-day readmission, how can the Office of Access Management help to make sure appropriate follow-up appointments can be secured?
Yeah, so that probably applies much to some of our community practices, especially. And I would say, and I can't speak 100% for this, but I would say from what I know, at least in the population management part of our practice, if there are individuals at high risk, there's work within population management to flag those patients, whether they're in the hospital or not, and have case managers who might be watching out for them, so to speak. Now, if it's maybe a patient who's not impaneled in the practice, comes into the hospital, a lot of what we do is reliant on the dismissal team. So in the hospital, if let's say, just playing this out, if a patient is seen and there's in our practice in neurology, maybe a patient with a stroke or seizures or things like that, oftentimes this outpatient arrangements will be done at the time of dismissal so that it's done before the patient leaves the hospital. I think the other piece would be, well, what happens if the patient, goes somewhere else or they don't follow up? We have mechanisms in place to try to close the loop on patients if they don't show up, or let's say they reschedule, or I wanted to see them in 30 days and it didn't happen. We have reports that can tell us, if people have missed those, so we can follow up with them. I would say a lot of that really rests on primary care and community in the community practice. Although we have transplant patients, oncology patients too. Many of those patients who, if they're followed at Mayo Clinic, have care teams that are really following them and making sure what labs they need, what follow-up they need, and making sure that's happening. So a lot of it is on the care team in the practice to make sure those things happen.
Sure. That makes sense. Looks like we've got another one here. Dr. Crum, for the Office of Access Management and your work with your internal departments, how do you know your stakeholders are satisfied? Is there surveys, or how do you get your feedback from those internal departments that you work with?
Yeah, that's a good question. We talk about that often when we do surveys. So we do send out surveys to our colleagues in the departments. Typically, these are what I refer to as our practice chairs. So they're the physicians that are most active in access in each department, and their administrative colleagues, usually an operations administrator and or operations manager. And so we do send them surveys every 1 to 2 years to just get feedback. What could we do better? What do you find value in? I would say we oftentimes get feedback either way too. We get feedback like, yeah, this is really helpful. And sometimes we definitely get feedback that, you're just giving me more stuff and I don't understand, I don't know what to do with it. Or, you're not talking about this. This is our problem. So I think we get both. We both get direct feedback and we try to solicit that through surveys. And I think it is important. We oftentimes sit around thinking, we do this all the time. But again, we're interfacing with a practice where we're interfacing with people that are doing lots of different things. If you're an administrator of a department, you're dealing with all kinds of stuff, and access is but a piece of that. Mm-hmm. And so we really do think about, how can, if we're going to do something new, how are we going to make that useful for the consumer, which is really the departments in our case. We also try to get feedback from more upper level leadership. So I talked a lot about how we work with departments, and that's true. But we also work a lot with our institutional leadership to help them understand what's going on in access. They ultimately are setting some of the strategic visions for the whole institution, and access is a big part of that. So we also solicit feedback from them. We meet regularly with our institutional leadership, partly to get feedback on what else do you want from us, or what do we need to do more of or less of. So that's more just directly solicited to them.
Sure, that makes sense. Brian, what are the most important metrics that you track that you found helpful in the projects that you've worked at?
It really depends. It depends on the situation and the type of analysis you're doing. But usually it's a combination of multiple metrics. The metric I mentioned about the time, that seemed to be a common factor, but certain practices and certain patient populations may have different types of metrics that are important too in a weighted manner. So the answer is it kind of depends, and it's usually not just one answer, it's usually a combination of multiple metrics.
Sure, that makes sense. Ooh, either one of you could take this one. Discuss the possibility of patient self-scheduling. Any barriers or opportunities?
Yeah, I can certainly talk about that. Before I do, I'm going to add one thing to what Brian just said.
Yeah.
And I didn't say it in our question and answer, although I should have. So one of the myths is there's a metric. There's one metric that will tell me what to do, and I think we run into a lot somebody focusing on one thing, and it's tough, but in reality, you really need kind of a suite of metrics. You can't just look at a fill rate and know what to do. You can't just look at, how many patients have I seen and know what to do. So I guess that's always another challenge we have is that, there's a dashboard we look at. There's probably 10 to 12 things we kind of look at high level to give us a bit of a picture. So that I just wanted to mention that. But the self-scheduling, certainly be happy to talk about. It's, as I mentioned, expectation of patients. What you can do in other businesses is you can self-schedule. And so there's a lot of interest in doing this. Mayo Clinic is getting into the game. We've started small pilots of self-scheduling. And there are different types of self-scheduling that can be done. And so I think we definitely will get into this. The challenge we have is that a patient may be coming for a itinerary or a package of care. So if you're coming for one appointment, that's one thing. If you're coming back to your primary care doc, or it's a well child, or a physical, or an acute problem, where we're challenged is a patient may be coming from long distance. They may have to see 3 or 4 different providers, get testing done, laboratory studies, radiology. And so how could we possibly expect a patient to know exactly how to schedule that all correctly? And, again, future state, maybe we could do that. But that's probably our biggest challenge is that, for better or for worse, a lot of the scheduling happens because somebody remembers, okay, I know what to do, I know how to do it right. The system definitely helps, but there is some element of human interaction that's needed. So that's probably the challenge. But for things that can be fairly straightforward, I need a radiology exam, I need a lab test, I need a single appointment, or potentially a brand new patient that's never been here that is maybe local who can come for an appointment and then get the rest of the things set up after. Definitely opportunity. We would like to explore that, but we are going into it starting very small and learning from it. And some of the very even initial pilots we started to do, we've uncovered things that, no surprise, is not simple. There's complexities. Even in what seems like simple things, it isn't always so simple. And we're very much attuned to not providing an experience that is seen as dissatisfying for the patient. If it's frustrating, like, oh great, I can self-schedule, but then you can't get anything done and it's more time consuming, nobody will use it. They'll just pick up the phone and call, which is okay too, but we would like to get into it definitely.
Sure. All right. Looks like for both of you can weigh in on this one. What are some of the challenges you foresee related to patient access for Mayo Clinic and for healthcare providers in general? Are you seeing any major trends in healthcare that might impact or have a significant impact?
Well, I think on our side of access, certainly one of the things we will need to deal with is just reimbursement models changing. This has started in some parts of the practice, but if you think about how medicine has operated for years and years and years, it's really been a fee-for-service type of arrangement. And as things change into reimbursement, maybe based on population health or capitation, that will change how access needs to operate. And I mentioned that our job is really from the time a patient wants to come and they get seen and go home, but access also really is not just face-to-face visits, but it might involve telemedicine, as was alluded to earlier, or other forms of access that aren't really face-to-face in the office with the physician or a provider. So I think the reimbursement models will change how we approach access, I think. And as I mentioned, telemedicine is another opportunity we have to practice outside of the bricks and mortar of Mayo Clinic. And we've done some work in using video to take care of patients at a distance. I think that is something that will probably continue to grow. And I think patients, rightly so, will be asking for that. And where we are located, certainly a lot of patients are from around here, but a lot aren't. And so a trip here could be avoided by using some of the telemedicine approaches. So I think those are a couple trends that we will have to react to.
Sure.
I think over time, what's going to probably happen is some of these predictive models we put up here are probably going to be integrated into the system. We're going to be capturing information ahead of time and using that information in a proactive way. Say the patient did want an earlier appointment, we put them on a list and we automatically bring them earlier appointment if somebody cancels. There may be other things we could do too to manage the risk. In a sense, it'll become like a risk management system as well, embedded into the process. So I'd love to see that as a feature.
Sure. All right. All right, Brian, can you share a project or two on patient access where manager and engineering staff have been involved? What was the involvement and how did they add value?
So, the project that I was just referring to was where we kind of added value to that process. We were trying to figure out a way to be more nimble in our processes. The patient demand fluctuates quite a bit. Mm-hmm. And so knowing how to match the supply with demand is super important, and knowing when to open up the right type of slots at the right moments. In other words, kind of a just-in-time approach. That's what we tried to do on that project. And so the project I highlighted only talked about a piece of it, mm-hmm. but the idea is to make sure the supply and demand match at the right moments for the patient. Again, the idea is right patient, right provider, right time.
Sure. And I can think of another project example would be something just even a little more simple to say. We had highlighted, can you go into ENT or can you look into urgent care, where it's just a quick data analysis and some observation, and working closely with OAM to make sure that all the data works out, and that ME&C is helping OAM kind of in collaboration with those two projects. I'd say Brian's got a really good example of a high level, very large modeling approach. We've also done just small ones, working with OAM in those projects to try to get things figured out as well.
Yeah, I would add too, and Brian had some involvement as well, trying to model appointment offices and understanding what staffing do we need, how many staff do we need, yeah. Which offices are understaffed. It's hard to say any are overstaffed, but which ones are understaffed. We hear oftentimes we need more staff, we need more staff, we need more staff, and we never really had good metrics on how do you compare to other appointment offices? And as I mentioned, the 56 number, maybe 56 different offices to figure out what's the staffing. And so that's another example where ME&C helped model, which areas seem to be understaffed where we focused on first. So that's another example of a type of project that's been done.
Yeah. All right, Dr. Crum, this one might be for you here. How do you know the Office of Access Manager is doing a good job? Is there patient feedback or patient survey?
Definitely patient surveys, yes. And so we talked earlier about getting feedback from departments. So this is a good question because ultimately we're trying to help patients. So we do. We definitely have information from Press Ganey, from patient experience, from the survey that they get, and we're all patients at Mayo Clinic too. We get the surveys, and there are some questions that ask about appointment scheduling and access, and we get that information within OAM, and we can look by department, and we can see where areas seem to be doing better and worse. So we definitely have data that we can use. Now, if you're used to looking at the questions on patient experience surveys, sometimes you need to know a little bit more. So there may be a question and you're not quite sure what that means. And so we do partner with our patient experience group to sometimes dig a little bit deeper to say, okay, here's the question, here's the feedback, what does that really mean? Sometimes we take that even to what we call patient family advisory councils. So most departments, as well as the institution, have groups of patients who are in essence sounding boards for us to ask questions of, to say how could we do something better, or where is your frustration? So we can take it to groups like that. And so we definitely get that. And then our patient experience group we work with, and I would say both good and bad. Clearly, if patients contact them and say, hey, I had a great experience, they share that with us. But also, on the flip side, if patients say, this was not what I expected. I was expecting X, I got Y, and it had to do with access and scheduling, we hear about that, and that's okay. And oftentimes, again, that's what we talked about, the one-time thing, to dig in what happened, and learn from that. So we certainly do learn from those anecdotes or from those experiences. And sometimes those things educate where something was built wrong or they needed to be updated and it just hadn't come out yet. So those are very important. So I think survey, individual patient feedback, our patient family advisory councils, we really do utilize all those things.
Oh, that sounds good. The combination of the patient and the department feedback.
We get a lot of feedback.
Yeah. All right. Well, that looks like that's all the questions we have for today. I'd like to thank our guest speakers and everyone for attending our Management Engineering and Consulting webinar. If you are interested in reviewing our previous webinars, you can visit our website at mec.mayoclinic.org, or our contact information is listed on the slide. Thanks again.